Hello, my name is Lisa Garlington, and today we're going to be talking about antenatal betamethasone. I will be addressing second-year nursing students in a associate degree nursing program. Our objectives for today are going to be identify and describe risks and benefits of corticosteroid administration for obstetric patients, apply knowledge of antenatal steroids to tangible obstetric scenarios, and synthesize information from the lecture and case study to verbalize essential teaching points in nurse-to-patient education. This is the sound of newborn lungs, which every mother rejoices to hear when her baby is born. It's the sound of strong lungs that are functioning as they should. Today we're going to talk about specific corticosteroids use when fetal lungs are not fully developed and are unable to produce the cries needed to clear the lungs of fluid and exchanging oxygen in a newborn body. Next, we have the pathology of lung development. We have combining endoderm and mesoderm cell layers. The endoderm is the innermost tissue or germ layer of cells. The mesoderm is the middle layer of the three germ layers that collaborate during organogenesis or the forming of fetal organs. The embryonic period from 4 to 7 weeks is when the lung buds are formed, combining cell layers. The lungs play a huge role in anatomy, not only for oxygen and carbon dioxide exchange after birth, but they also play a role in amniotic fluid production and surfactant production. This happens in the late second trimester and early third trimester. The amniotic fluid acts as a cushion. It protects against infection. It maintains fetal temperature. It helps with the ease of movement of the fetus in the womb and provides nutrients to the infant. Physiology of neonatal preterm lungs. So when an infant is preterm, there is typically an insufficient amount of surfactant that is produced. The surfactant lubricates the alveoli and keeps them inflated when there's little air in the lungs, like whenever you exhale. Surfactant production starts between 26 to 29 weeks gestation, and by 35 weeks there should be sufficient surfactant to avoid need for additional surfactant treatment at delivery. When we do not have sufficient surfactant, then the lungs have difficulty expanding because of the alveoli not being lubricated, and then that leads to poor oxygen and carbon dioxide exchange, which can then lead to respiratory distress syndrome. If this is the case, then infants may still require respiratory support at delivery. And other risk factors that can lead to respiratory distress syndrome include Caucasian race, male gender, maternal diabetes, and family history. A little information about our drug is its brand name is Celestone, the generic name is betamethasone, and our drug class is corticosteroids. So with our next slide, we will be addressing our first objective, which is the mechanism of action. We're going to identify why corticosteroids would benefit a preterm newborn, and that is because they bind and activate nuclear receptors. Betamethasone binds and activates nuclear receptors. It promotes mesenchymal thinning, which reduces the blood vessel to airway distances, allowing appropriate gas exchange, which then allows for surfactant production, which we know we need for successful oxygenation and carbon dioxide exchange. betamethasone treatment. So we are talking about antepartum patients, obstetric patients, who are between 24 to 34 weeks gestation. Whenever they present with preterm labor symptoms, contractions, bleeding, leaking of fluid, if we expect that they're going to deliver within 7 days, then those are going to be the patients that we would start this treatment for. The medication is given injection via the muscle intramuscularly. It is 12 milligrams, and it would be given 24 hours, every 24 hours for 2 doses. Something else to keep in mind with this medication is that it increases blood glucose levels. This will be extremely important for your moms with gestational diabetes because they are already at risk for hyperglycemia. So we'll just be on the lookout for that and know that it can last 2 to 3 days from your injection. Some anticipated questions from this lecture. I would expect how early can antenatal steroids be given? And the earliest is 24 weeks because that's when viability would be. Is 1 dose sufficient if given once and then weeks pass before the next preterm labor episode? Newer studies are showing that when several weeks or a month have passed and they've had 1 episode of preterm labor, another rescue dose of steroids can absolutely be given if they are having another episode of preterm labor later on down the road. And then, are there any cases of preterm labor when corticosteroids would not be indicated? Typically, they're safe for everybody. You're just going to be looking for if the mom has gestational diabetes and be on the lookout for that. And then if there's any allergies to steroids, those would be your contraindications. So then after addressing these anticipated questions, we'll break into small groups for a case study exercise to address our second objective, which would be applying the knowledge of antenatal steroids to tangible obstetric scenarios. And then the second exercise will be done by dividing students into pairs so that they can synthesize the information. This is our third objective, where they will practice role-playing for patient teaching, patient education regarding risks and benefits to antenatal steroids, things that they should expect, how the medicine will be administered, side effects that they could have from the medications, just any important teaching points. And then we would have 2 students come up and demonstrate their role playing and the teaching points in which they shared with each other. So this concludes our presentation. Thank you very much for watching.